Bütün hocalarımıza ben çok teşekkür ediyorum. Katıldığınız için size de teşekkür ediyorum. Aslında bir çekiliş yapacaktım. Çıkana ATLS kursu ücretsiz olacaktı ama vazgeçtik şimdi. Başka bir zaman çekiliş yapalım. Öyle değil mi Mustafa Hocam? Zamanımızı da açtığımız için soru cevabı arada alabiliriz. Hepinize katılımlarınızdan dolayı çok teşekkür ediyorum. Ara veriyoruz. Sağ olun. Evet, aradan sonra bir oturumumuz daha var.
Test, test. Ok, ça marche.
Emre.
Normalde onun bir tane olması lazım. Abdullah mı? Faut que tu appuies pour parler. Ouais, mais moi, tu vois, il est...
Test.
Ok. Hello, from Maya.
Yeah, hello.
Okay, happy to see you here.
Thank you.
We must begin. Okay, From Moya begin his presentation. He is the director of International Medical Service at the Vitos Xanit International Hospital in Malaga. And I invite you to begin, Dr. Maya.
Okay, I don't know if you loaded the presentation in the system.
The sound is not too...
Now the sound is better now?
They are working. Okay.
Okay. So they are working on downloading the presentation.
Okay.
Yeah.
Thank you to be here. You have a very difficult situation now, we have learned.
Yeah. I mean,
How are you?
Things are going better, fortunately. And well, I think my dad is coming out of the hospital, I think, soon.
Yes, we have heard. Yeah. Okay.
Yeah. Okay, very, very happy to be.
How is your dad?
Yeah, he's fine. He's getting better.
Okay,
Yeah.
super.
Yeah. So yeah.
We hope to see you next year in May, perhaps.
Yeah. I mean, anytime if nothing like this happens, I mean, I will be happy to see you at all. So yeah, no problem.
Yes, we're waiting you, Dr. Moya.
Yeah.
Okay.
Yeah, thank you.
They are preparing the sound. Okay.
Yeah, and I think they are down. I mean, I've been informed by the WhatsApp that they are downloading the presentation as we speak.
Okay. A few minutes.
Yeah.
Okay. Dr. Maya, how many years are you working in emergency medicine?
Well, I mean, our hospital is a private hospital. We see about 80,000 patients per year. I mean, that's the pre-pandemic, obviously. And we are usually, all our doctors are senior doctors. We don't have residents being a private hospital. So obviously, is different from a public health hospital in which you have residents and so on. So we are about four four doctors in the morning, four doctors in the evening, and two doctors in the night, 24 hours, 365. And we have also two consultant pediatricians because the pediatric emergencies are divided in Spain and the pediatricians specialize in pediatric emergency care run the department. So apart from four, and two emergency physicians all the time, I mean, with the standard of consultant, we have two consultant pediatricians most of the time on the other side. Okay, I think I got control now of the presentation. I mean, I don't know.
Thank you, Emre. It's okay. We can begin. Okay. Okay.
Yeah, I think. Let me see if I can.
The sound, please. It's okay.
Yeah.
Okay.
Yeah, we can start. I mean,
yes, you can. You can start. We are listening to you. Okay.
Yeah, but I cannot scroll down the presentation. That's the only thing. Yeah, now, I think we can now. Yeah, definitely. So we'll start. I mean, merhaba everyone, and thank you, IPAD, for inviting me to participate even online, and always to invite me to a lot of projects and congresses and conferences. So thanks to everyone, especially to Professor Kander and all of you guys. I would like before to think for everyone involved in emergency medicine to think about what we do now in emergency medicine and how busy our emergency medicine departments are and whatever. I'm going to present a project called Smart ER that we develop. I mean, it's been developed mainly in the UK by a colleague of mine called Dr. Anjin Mohamed, that he runs the emergency department in Doncaster, and that's where this project is been proven and it's been tried for the last 4 years. So I would like all the audience to have an open mind. I got a lot of slides, but I know that we are restricted in time, so I'll try to make it as fast as possible. I only want to share the concept because this is something that probably we will need a conference in itself. If you have any questions or you are interested more in this project, you can always contact me or Dr. Mohammed in the UK. And then if you want more info, we will be happy to share it with you. So obviously emergency medicine now is a global problem, not only in the developed world, also in the low middle income countries, because we are increasing the demands every year. We have limited resources, and there are a lot of implications, health, financial, and political. The concept of the Smart ER project is we have to understand what the downtime is in the emergency department and elsewhere, that we want a Smart ER. I mean, we had the idea that the patient has to be the center of the process. This Smart ER works better when we have an increase of activity. That is, a bit strange when we are talking about emergency medicine, because it seems like increasing activity is always worse. We think that increasing activity for us is better because the machine engineers everything better, that the patients are part of the solution, that we not only look at the in-reach care, which is when the patient is in the emergency department, also the system looks at the outreach care. We try to bring order versus the chaos that usually happens in the emergency departments. And we believe in the major emergence of emergency medicine. Things have to change. Obviously, we need a change. We need to innovate. We need to be modern. We have to embrace technology. Obviously, if we center the process into a patient, that will lead us to have a patient-centered care. We have to rethink the relationships between the patients and us. The pressure is not only because of the blockage of the emergency departments in the exit. Also, when people come to emergency department with low acuity attendances, and I think that happens in every emergency department in the world. The challenge, I mean, I think there is a format problem, with the slide, but anyway, I don't know, you can see that. I will tell you that the emergency departments are the most utilized services in acute, the most utilized department in acute services. Just to give you a figure, that usually nearly half of the population, between 35 and 50% of the population of every nation, attend the emergency department in 1 year. So in a country like ours in Spain, that we have a population of approximately 40 million, 42 million people, nearly half of that people, so we're talking about 20 million people come to the emergency department nationwide in our country. There is a variable demand, and we know that. We don't have a lot of technology to support us. I mean, it's very variable, the technology that we use in the emergency departments. We have electronic health records, we don't. So we need and require solutions that perform well under high demand. No, we think that the care doesn't have to stop when the patient leaves. It's got to be a continuity of care, when the patient goes. We have to have a measurable follow-up. Obviously, I think with the technology and with all the things that we have at our disposal, we need digital health solution. We provide InReach, with which we want the patient to engage while he is in the department, and the outreach, which is we need to follow up this patient where they live. So obviously we are talking about innovation, development, and improvement. We try to think ahead for these things. Obviously, we develop this depending on where we are now and we are going to be in a few years. So we know that it's going to be an increase of demands, increased morbidity. The patients are changing. The patients are more pluripathological. The patients, keep living longer. And obviously, they got more expectations. There is a problem with the staffing. I mean, you asked me how many staff we have. It's a problem worldwide. We haven't got enough doctors, enough nurses to attend the population at the moment. Obviously, there's a worry about the cost, the value for money, how efficient we are, and obviously social and IT changes. And that the last one is NHS strategies, because obviously this presentation and this system is working in a national health system hospital in the UK. There is something in the format of this slide anyway when we pass it there, but this slide only shows that there have been some strategies in the UK in the national health system, some projects to try to implement technology and digital workforce in the system. So as long as 2011, they started thinking about how they could do it. But now, I mean, that was obviously a thing for the future, but where are we now? What do we do in the emergency departments? I mean, we haven't changed the system. We haven't changed the way we work in, many years. Probably 60 years we've been doing the same, which is the patient arrives, the patient registers, the patient waits, the patient waits, the patient waits even some more. Then is seen by a healthcare professional for consultation. They discharge, transfer, or we admit him. There are a lot of social, technological, and patient expectations change over the last decades that I don't think we are ready, and we are catering for it. The emergency departments fail to keep up with these developments. That's a fact. I mean, I think everybody, the audience, and everybody working in the emergency department, we got this every day. And obviously, from a clinician perspective, where are we now? Obviously, the departments are always busy, under pressure. The waiting times are longer. We haven't got sometimes a good record keeping. There are many complaints and concerns that we have to face. It's very difficult in the emergency departments to establish accurate audit and data collection. If there is these inefficiencies in the medical staff, that leads to poor performance. There are many duplication of processes. There's a lot of time that we have to spend writing clinical records. Sometimes, we fail to meet targets that even our politicians or or the guys in senior management put on us. We try to manage everything as a crowd management, no as an individualized patient's care. I mean, it's only a review of the time that we spend with the patients. I mean, F1s and F2s in the UK system are like residents, junior doctors, and you can see that they spend most of the time with the patients, probably because they are less experienced. But it's a lot of time that we, especially if you see this is the time that we have to spend writing history, and you can see that it's a lot of time, 71%. We all know that. I mean, everybody that works in the emergency department know the time that we spent doing very, very valuable tasks that we could do or we can spare, if we have some technological help. And the patients, 80-90% of the time that the patient is in the department, they are simply waiting because they get triage, they wait, they are called, then they wait, to be seen by the doctor, then the doctor orders some tests. I mean, think about it, because the journey, I think, of a patient in the emergency department is well known by everyone. The longer the patients wait, the less time the clinician has with them. So it's an inverse relationship. The longer the patients wait, the more the complaints. It's that direct relationship. I mean, most of the complaints in the emergency departments are because they are waiting, or the patient perceives that they are waiting inappropriately. Frustration at doing nothing for several hours, waiting for something to happen. There is a feeling of inadequate consultation after the long wait. Is that it? There is a feeling that information wasn't conveyed bilaterally. And during post-consultation, there are communication issues that we all know. I mean, you can see in this slide that the downtime is the time that the patient spends in the emergency department. So it's a big percentage. And then compared to the time that the patient is spent interacting with us or receiving care. So what we do is trying to get downtime solutions. Is what can we do in that time that the patient is waiting and it seems to be wasted. So we are creating, and the concept of downtime, of trying to sort the problem out. What we try is, we said is embrace technology, trying to get, a patient-centered approach solutions with current NHS concerns and future design. I mean, we have to bust the myth that the patients don't know anything, that they are part of the problem, that our perception that they are most of the time satisfied even with brief interaction and explanations, that they don't have anything to offer to contribute to the care. I mean, we disregard them, really. Usually, we also say that the patient are our enemy. They are drunk, disrupted, angry. Obviously, the lack of communication also we blame to how busy we are. We think there are no better ways of doing things, and basically, most of the time, we think that we need to build walls and to try to separate them from us. As we said before, we are offering more crowd management and not personalized care. So the downtime solution, that's why we started with this project called Smart ER. So we want to use downtime more efficiently. If the patients are waiting, can they help? I mean, they possibly have 80-90% of the data that we need to make the diagnosis. I mean, probably if they could have more time telling us, what's wrong with them, obviously, probably they will give us more info, and then we probably will reach diagnosis and will reach a better care for them. We can engage with the patient from the moment that they start waiting. Everybody has a smart device now at the moment, smartphone, tablets, laptops, and everybody comes to the emergency department now with their mobile phones. If not, we can provide kiosks in which the patients can interact. We can even provide with tablets or any laptops or anything that the department can provide. We can give an application that can give some ownership to most patients while waiting. We can improve the experience, and we can improve performance and efficiencies. We can develop applications in other settings where the patients are waiting. So while the patient is waiting, we can do data collection. I mean, the future, we'll talk about the data analysis. We reduce the variation in one of the part of the system, so it reduces the whole system variation. Um, the aim is to reduce variation in data collection. I mean, how many times the patient changed the history from one healthcare provider to another. I mean, from triage to be seen by the doctor, the patient sometimes, like change the history, and that confuses us. And imagine if the patient is writing his own history in the on device appears in our screen. That's in our smart ER is about. Obviously, is consistent with any public health, with any healthcare organization. Obviously, we are trying to develop algorithms, obviously based on the information that we are collecting. The data analysis can be supported, and the data collection is even sometimes direct and live happening at the same time. So this is what we do now at the moment. The patient attends the the emergency department, he registers. If he's suitable for the smart ER, he starts interacting with the smart ER, even via console, via tablet, via their own device. The history is taken from the patient because the patient is writing the history in the system, in his tablet or in the kiosk or in their tablet. Obviously, you can see all the travel and all the information that we can download. Obviously, we can start in identifying all the toxic habits. We even can start even interacting the system automatically, can give advice. They can be waiting down and then interacting with the system at the same time. And we can identify allergies. We can even interact with friends and families. We do a summary to confirm accuracy. Obviously, the portal and the system, when we see the patient, is open, and then everything is uploaded, we submit, and we can print it on a scan or a file. So who is suitable for a smart ER? Usually are patients that can interact with the system. Obviously, they have to be alert and orientated. They are patients or carers have to be able to use applications. I mean, not to use a mobile device that a lot of people obviously do. Obviously, no contraindications to use, because this is not to stop the flow of being triaged and be identified as a critical intervention needed. And obviously, depending on the ability of the application. And you will see, obviously, that most of the people that come into the emergency department on a daily basis are suitable for the smart ER, because approximately we found that 80% of the patients that attend an emergency department daily are suitable for this, because, I mean, that happens in every emergency department in the world. I mean, 80%, really between 75 and 80% are people that come ambulance and are people that come with a minor illness. Even now, after we started developing and putting this system in motion, we are trying to make change in order for this system to be applicable to major illnesses as well. Obviously, it's more inclusive because we can put this smart ER in many languages. Obviously, the UK is a multi-ethnic country with people speaking lots of languages, and then we can put the system, and and we've been using the system I think it's been translated already to 17 languages. This is how the architecture overview on how the smart ER works computer-wise. I mean, sorry, this slide is very, very, very thick, but mainly you can see, and as I said, I'll be happy to share this presentation and to have more information, because a waiting patient can produce a lot of information for all these 1, 2, 3, 4, 5, 6, 7. So it can give us information, obviously the history from the patient. It can help us to research. It can help us to advertising, to advice, to education, to even pediatric care for the kids, friends. So the implications of a patient waiting and downloading information to us and to the system are massive, and we are seeing that. And smart ER obviously communicate. Smart ER has been developed to address the in-reach problem. It allows a patient to enter clinical data regarding their condition, optimize questions of help and determined by the condition of the patient. Obviously, using eSmartER, we can coordinate the in-reach and the outreach care. Post-visit digital care models and they are developed at this moment based on conditions determined in the department. We can auto-generate information more efficiently and allows a secure personalized patient record to be created by the patient for the patient in the health space. And obviously the outreach beyond the emergency department is the digital health allows care models to extend beyond the emergency department because the patient is going to be going home with the application downloaded and we still can communicate and the technology with the technology at our disposal. I mean, everybody now has a smart device and we know how we interact now with the digital technology. And even we can send personal health information and outcome of the data through the patient health. Obviously, it will allow and is allowing some interaction with other care providers, GPs, nurse practitioners, social workers, etc., etc. Obviously, we are seeing that provides an insight in the models, to determine how effective, how efficient, and how satisfied the patients are. And this is again a total healthcare platform which we want to do with the Smart ER, in which the patients are the components of the solution, and through the Smart ER, we interact and we can create a lot of data to help the patient and to personalize their care as much as possible. Obviously, we are seeing that Smart ER is providing at the moment key operational and clinical benefits to the department and the patient. A smart communicate allows patients' health space to be created and populated with personalized conditional information, and the outreach digital care models can be developed for patients, which obviously put the patients at the center of the care process, allow care to be seamlessly delivered across the care spectrum. The models can be built to include all providers, and models can interoperate with the system, and the model can be measured and optimized to provide optimum combined care on personalized basis. So it's all about trying to get the patient at the center, to follow it up, and to interact with other systems of healthcare. We can do a screening of patients. We can obviously know about their the toxic habits or anything that we can identify it and we can help with. For example, if they are not doing enough exercise, we can provide with information about how can we do exercise promotion. Is all about how to send information to the patient health space. The platform can be used to connect the patient to community-based services like Aspire, or that's in the UK, or social workers or whatever. Obviously, it's an opportunity to educate, inform the risks, and try to change health behaviors. That is one of the problems that concerns us more in the public health system, that we are not being very effective overall to change our habits in our population. Obviously, we can increase consistency, reduce the variation, intra-hospital, inter-hospital, inter-primary, secondary care. We have to have central control. We have a central updating. We have bespoke elements, research and updating. And obviously, this is down to the education medical information system that we can do all this with the Smart ER, because we can advise, do all the information and improve how we can interact with the patient overall. In other settings, the waiting patients even can help us, with all the information that they give in the Smart ER, how to create new outpatients and how to refer them to the appropriate specialist, interact with pre-hospital. We can interact with radiology. We can interact with everything. And we are seeing that. We have a proof of concept because everybody, probably the audience is asking, and does this work? Obviously, it's been working for 4 years. And this is the first trial that we did in a minor injury unit. We did a trial for 3 months, and we did 6 weeks refine, which is in our training and setting everything in motion. And we did a 6 weeks testing. We tested this with 70, 80 patients per day, 12 hours a day, and it was put into and the EMIS integration into Symphony. And obviously, we target the patient satisfaction, the clinical satisfaction, and productivity. Um, Sorry that we cannot see the results, but everything because of problems with the slide. But if you see what we tested, patient satisfaction, clinical satisfaction, and productivity, everything was positive. Patient satisfaction increased. The clinician satisfaction obviously increased because think about that while the patient is waiting, he's interacting with the system and you got all the information in your computer when you see the patient. And obviously the productivity increased because it reduced the time that we have to be writing notes and doing times, especially the healthcare practitioner. That was the, sorry, I mean, see if I can pass. Yeah. Obviously, one thing that we are seeing after we implemented the Smart TR is data is power, and this is in other way we are now. I mean, we have been acquiring 4 years now since the system was put in motion of data, and obviously there are some questions about how we can comply with the data law protection, but we have all these what we saw at the beginning is now we have it because we have a lot of data. Now is where artificial intelligence will have to help us to try to work out what we're going to do with this data. Sorry about this slide. I mean, this is what I wanted to show from before. That is about this is all the results that we are seeing after applying the Smart TR. The patient gets more personalized care. They communicate bilaterally with us. Obviously, the waiting times are decreased, and the processes are improved. There is more satisfaction. There are better consultations. There is better post-consultation communication, and is less likely to return. That is one of the quality indicators of the emergency departments, and we can use it in different languages and modalities. For the healthcare practitioners, obviously, we have more accurate history. They are already written. We don't have to write it down. A better communication. We'll have more time with the patients, interacting with them. We have less time with the computers because the patient is already writing the history to us in their device and appears into our screen. We are more efficient. Obviously, the language difficulties are overcome because the patient is writing in their own language. Even disabilities difficulties overcome because we can optimize another time with them. In terms of the department, obviously it's a cost. It will reduce the cost. We increase the income. It's better flow. We increase the productivity. Less complaint. There's less negligent claims. It's better data. It's mandatory with all the quality indicators. We have central management of real-time data, happier patients, and from the public health system, obviously, is very advantageous as well because they have better data consistency, they reduce the cost. It's applicable across other areas, even in our primary care and whatever.
Dr. Maya, can you conclude, please?
Yeah. I mean, so obviously what we do is integrate this into what we already do, which is a registration triage, and the Smart TR will apply. And the summary concepts are we have to understand the downtime. Obviously, I think I try to probably make you aware of that. We have to change into a patient-centered process. The process works better with increased activity and it provides better engineering. Patients are part of the solution. We can improve the in-reach care. The outreach care is a third solution to constraints. We have to bring order versus chaos, and it's the emergence of emergency medicine. As Einstein said, doing the same things again and again and expecting a different result is a definition of madness. The only thing that is constant in the universe is the speed of light. Everything else is relative, even time. So this is what the system is. We hope and happy to answer any questions that you have. And if you want more information, happy to provide this as well. Teşekkür ederim. I finish now. Thank you.
Thank you, Dr. Maya, for this useful presentation. Do you have any question? Okay. Okay. Okay.
So for our next presentation, I will be presenting my colleague, Nazmin Guler, who's the expert in medical hypnosis and emergency medicine in France. She will be talking about the uses of hypnosis in emergency medicine. We have a question here.
Yes. Okay, Türkçe konuşayım mı? Okay, if you want I can speak in Turkish. It's not a problem for me. Okay. It's better for me.
No, for sure.
Antoine, it is a problem for you? Okay. Test test test. Beni duyuyor musunuz? Okay, süper. Çok güzel. Şansıma Türkçe sunuyorum. Daha hızlı sunabileceğim ve daha çok bilgi verebileceğim size. Çok mutluyum bu sebepten dolayı. Antoine, tu comprends tout? Yes? Okay. I understand everything. Bildiğiniz gibi acil uzmanıyım. 2005 senesinde mezun oldum. 2012'den beri acilde hipnoz uyguluyorum ve uzun yıllardır tecrübem var ve bu konuda inşallah sizi ikna edebilirim acilde hipnoz uygulamanız için. Bu konuda zaten Başar Hoca ve Mehmet Gül Hoca ile düşüncelerimiz var. Belki yakın zamanlarda size bir atölye çatısı altında bir eğitim teklif edebiliriz. Bunu hatırlarsınız. Ten dizisindeki fakir. Deli olduğumu düşünüyor musunuz? Yok. Sizce benim gözlerime bakarak beyninizin kontrolünü alabilir miyim? Alabilir miyim Behçet Hoca? Okay. Okay. O zaman bakalım alabiliyor muyuz, alamıyor muyuz? Keşke alabilseydim. Gerçekten hastanedeki yönetimdeki insanların beynini çalardım ama benim gayet işime yarardı. Öyle bir gücüm, kuvvetim olsaydı. Bildiğiniz gibi acilin ortamı çok stres, çok büyük bir anksiyete yaratan bir ortam. Özellikle korku, ağrı, stres, öfke, özellikle öfke patlamaların çok olduğu yerler ve gerçekten bu ortamda çalışmak ve yaşamak çok çok zor. Çünkü bizim de kendi ayna nöronlarımız var ve ayna nöronlarımız olduğundan dolayı bizde de çok kaldıramayacağımız duygular uyandırabiliyor ve sonuç olarak öfke patlamaları çok yoğun olan bir yer. Sizce tabii ki doğru bilinen yanlışlar var. Ki zaten bu sebeplerden dolayı yıllardan beri acilde zaten hipnoz uygulanmıyor. Yıllardır böyle. Çünkü işte psikiyatride yapılabilir, işte anestezide yapılabilir ama acil kesinlikle yeri değil. Ve ön yargılardan birisi işte bir zaman kaybı. Çok fazla ses var, hastaların direnci çok yüksek. Hele hazırlıksız kesinlikle olmaz diye ön yargılar var. Bakalım bunları bir bir yıkabileceğiz mi? Başlangıç olarak vaktimiz var. Son sunum olduğum için biraz 5 dakika fazla sunum ekledim. Size 2 tane video gösterebilmek için ilk videoyu gösteriyorum. Belki aranızda bazıları görmüş olabilir bu videoları. Tekrar gösteriyorum görmeyenler için. Omuz çıkığı redüksiyonu. Bu hastamız diyaliz hastası. Daha önce omuzu çıktı ve acile ağlayarak geldi ve dedi ki ben ilaç istemiyorum. Lütfen bana ilaçsız müdahale edebilir misin? Ben evime bir an evvel dönmek istiyorum. Haftada 3 sefer acile gidiyorum artık hastaneye geliyorum ve ben artık hastane görmek istemiyorum. Gördüğünüz gibi röntgene gerek yok, omuz çıkık. Hepinizin bu konuda zaten tecrübesi var biliyorsunuz. İlaç, serum takmamız gerekiyor, monitoraj, midazolam, süfentanil değişik ilaçlar kullanmak zorunda kalıyoruz. Hipnoz seansı genelde anestezi gibidir. Endüksiyon vardır, derinleştirme vardır, çalıştığımız an vardır ve ondan sonra hastayı uyarma vardır. Tabii bunların hepsini ilaçsız yapıyoruz. Serum takmadık hastamıza, dikkatinizi çekerim. Şu an endüksiyondayız. Yavaş yavaş derinleştirmeye geçeceğim. Özellikle nefes odaklı, nefesinizi takip edin şu an diye hastaya telkinliyorum. Gördüğünüz gibi aşırı gencim. Yıllar önce yaptığım ve hemen eğitimden çıkar çıkmaz yaptığım bir hipnoz tedavisi. Arkadaşlar videoları çekiyorsanız da sosyal medyaya koymayın. Çünkü gerçekten arkadaşlarıma, bu hastalara söz verdim sosyal medyaya sızmayacağını videoları. Çekebilirsiniz ama kendiniz için. Efendim? Ona ne söylüyorum? Nefesine odaklanmasını gerektiğini söylüyorum. Ondan sonra yavaş yavaş, şimdi bana lazım olan ne? Rahatlaması ve omuzunu hissetmemesi. Yani ilaçların yaptığı şeyleri ben telkinliyorum. Omuzunu artık hissetmiyorsun, rahatlıyorsun, kasların gevşiyor. Direkt telkin veriyorum ve yavaş yavaş zaten hastamız rahatlıyor. 5 dakika sonra redüksiyona başlıyoruz. Hastamızı genelde güvenli bir mekana gönderiyorum ve orada omuzunu bana emanet etmesi gerektiğini, yani disosyasyon teknikleri kullanıyoruz. Burada bana omzunu emanet etti. Arkadaş çekiyor ama biliyorsunuz normalde bu prosedürler çok bazen hızlı güç kuvvet isteyen prosedürler. Hastamız biliyorsunuz hiç bağırmadı. Bazen 2 kişi tutuyoruz biz acilde gerektiğinde.
Pas forcément exactement ce que vous me disiez, j'arrive pas forcément à suivre ce que vous me dites, mais par contre, je viens ça m'aide.
Şimdi prosedürü arkadaş kolu çekiyor, ben hipnoz uyguluyorum ama kendim hipnoz uygulayıp da kendim de çekebiliyorum. Bizim acilde özellikle omuz çıkığı, anterior omuz çıkıklarını biz acilciler tekrar yani redükte edebiliyoruz. Posterior ortopedistler, anterior biz yapıyoruz. 6 dakika arkadaşlar, biliyorsunuz acilde normalde 6 dakikada mümkün değil. O yüzden zaman kaybımı gördünüz. İlk ön yargıyı yıktık. Zaman kazandık. Çünkü normalde bu hastayı ben bizim orada critical care üniteye koyuyorum, monitoraj yapıyorum, ilaç yapıyorum, hemşire bulmam gerekiyor yoğunluğun içerisinde. Yani gerçekten yarım saat 45 dakikada ancak hazırlıyoruz hastamızı. 6 dakikada 1 saat içerisinde acilden ayrıldı. Vaktimiz olduğu için ikinci bir video gösteriyorum. Ondan sonra size ikna etmeye çalışacağım bilimsel olarak. Burada ufak bir çocuğumuz var. Bisikletten düştü. Annesi lokal anestezi yapmadan bacağını sütürasyon yapacağız. Bu benim tabii ki ilk başladığım zamanlarda ve o zamanlar biraz tedirgin hipnoz uyguluyordum ve böyle sesimi kısa kısa konuşuyordum. Çünkü biraz utanıyordum. Çünkü herkes garip garip bakıyordu. İşte bu ne yapıyor? İşte deli midir nedir diye. Çok sessiz konuşuyorum. Çocuğa tabii ki bir oyun yapacağız beraber diyerek sedyeye getiriyorum. İstediği, sevdiği bir oyunu yapacağını telkinliyorum. Ve tabii ki vizüel fokalizasyon kullanıyorum. Yani karşındaki bir noktaya bakar mısın? Onların tabii ki tekniği çok derin. Hani onu büyük bir eğitim gerekiyor ama noktaya bakabilir misin diyorum. Çocuk bakıyor tabii. Ondan sonra da istediği oyunu oynaması gerektiğini telkinliyorum. Tabii telkinlerken de aynı anda bacağına tabii ki direkt telkin veriyorum. Bacağı rahatlıyor. İşte bir yavaş yavaş bacağı uyumaya başlıyor. Bir daha artık hiçbir şey hissetmeyeceğini, bacağından hafif bir rüzgar geçtiğini ve hiçbir şey artık hissetmeyeceğini direkt telkin olarak söylüyorum bunu. Genelde çocuklara hipnoz uyguladığımız zaman gözleri genel olarak açık kalıyor. Yani ön yargı biliyorsunuz, gözleri kapalı, ondan sonra kendisini teslim ediyor ama burada çocuk gördüğünüz gibi hareket ediyor ve gözleri açık. Ellerini gördünüz mü? Sizce ne yapıyor? Oyun oynuyor. PlayStation oynuyordur muhtemelen. Git bir oyun oyna diyorum. Bizim biliyorsunuz gençlerimiz artık virtüel dünyada devamlı oyun oynuyorlar. Muhtemelen orada bir oyun oynuyor. Bakın yan tarafta ben çok ses yapıyorum ve çocuk çıkmıyor transtan. Genelde bu çocukları birkaç kişi tutmak zorunda kalıyoruz. Ben bir şeyler hazırlarken çocuk genelde ne yapıyorsun diye mesela soru soruyor, anksiyete içerisinde ağlıyor. Gördüğünüz gibi kendi dünyasında. Yarasını temizliyorum ve sütürasyona başlıyorum.